Hi everyone, my name is Ali Yıkılmaz. I'm a pediatric radiologist at McMaster Children's Hospital, and I'm going to talk about imaging of spinal dysraphism. After the introduction, I'm going to talk about the classification, then embryology, then review the imaging features, mostly of ultrasound and MRI. Spinal dysraphism is a spectrum of congenital anomalies characterized by defective fusion of dorsal midline structures. These dorsal midline structures can be skin, subcutaneous tissue, vertebra, meninges, and the neural tissue. These three terms, spinal dysraphism, spina bifida, neural tube defect, can be interchangeably used, and they mean the same thing. Pediatricians like the term spina bifida. Usually the radiologists like the term spinal dysraphism. And a nuance is among the pediatric neurosurgeons, they use spina bifida to specify only the bony defect, not the general term, but it's a common use to use all three. So dysraphism means bad sewing in Latin, so bad sewing of the back basically. Bifid means split, so spina bifida means split bifida. Spina bifida occulta is a very old term that is used to describe posterior bony fusion defect. It's called occulta because you cannot see the defect with your own eyes, you need x-rays. If you see it with your own eyes, it becomes spina bifida aperta. So as you can see in this paper, it was described as a normal variation, published almost a century ago. It is relatively common. The prevalence is between 12 to 23%, most commonly seen in S1, then L5, then S2 and L4. It doesn't progress or improve. You see it in a child. If you follow up the same patient as an adult, you will see that it has not fused, it remains the same. They are usually asymptomatic. Association with low back pain and urinary incontinence is controversial depending on the studies. And routine further investigation for isolated posterior fusion defect is unnecessary and should be case-based depending on the size, extent, neurological symptoms, and associated cutaneous lesions. To give an example, there is low risk in this patient with small bony defect in L5, maybe in the sacral vertebra as well, but in this one there is a very large defect in L5 and in the remainder of the sacrum, so there is high risk. So I wouldn't further investigate this patient, but this patient warrants further investigation. Spinal dysraphism is worldwide, seen 5 to 6 patients every 10,000 births. Folate deficiency is one of the most commonly known etiologies. When it was mandated in cereal grain products all around the world, there was a very significant, almost 23% decrease next year in the United States of America in 1998. Hypernatremia is one of the etiologies. Drugs, antibiotic use, retinoic acid exposure, and history of spinal dysraphism in the previous pregnancy. This increases the risk 20-fold. And low socioeconomic status. There are many skin lesions associated with spinal dysraphism. Some of these are of low risk, some of them are high risk. The low risks are telangiectasia, simple dimple, hyperpigmentation, capillary malformation, and congenital hemangioma, while the high risks are atypical dimple. I will explain later what is simple, what is atypical, then hypertrichosis, infantile hemangioma, Y-shaped gluteal cleft, and a tail or a skin tag. Spinal dysraphism can be categorized into two as open and closed. Open is called open because the abnormal non-neurulated dysplastic neural tissue is exposed to air. There is no overlying skin, and there may be a thin membrane but never a normal skin. Closed ones are covered with the skin, and they can be associated with a mass or without a mass. The closed spinal dysraphism without a subcutaneous mass can be associated with a cutaneous lesion or without a cutaneous lesion, so could be completely normal. In the old terminology, this group is called spina bifida occulta because there is no mass and you cannot see the lesion with your own eyes. And this group is called spina bifida aperta because you can see the lesion with your eyes. This terminology is not recommended anymore because you can actually see the cutaneous lesion. This is seen in 50% of the patients, so it is not actually occult. You can see half of the patients with a cutaneous marker. In this slide, I wanted to summarize the most common anomalies of spinal dysraphism. Here is the open spinal dysraphism. The most common one is myelomeningocele, 99%. The others are so rare. In the closed one, they may be associated with a mass or without a mass. And here you can see these anomalies. And here in this group, they can be categorized as simple and complex. And these are more complex anomalies and more simple anomalies. And I'm going to touch base one by one to all these anomalies. The nomenclature and description of spinal dysraphism can be quite confusing, so I wanted to summarize here. In the posterior bone effusion defect, there is absence of posterior elements of the vertebra, also called as spina bifida occulta, and this is a common anomaly associated with spinal dysraphism. Through this bony defect, when there is outpouching of the dural sac, as shown in black color, and the red is the skin, the dural sac is herniated without any neural elements, but just with CSF. It's called meningocele. In myelocystocele, there is outpouching of the dural sac along with neural elements and central spinal canal, which is filled with CSF. So two separate CSF-filled areas are herniated, and there are two sacs actually, and it's called myelocystocele. Limited dorsal myeloschisis is characterized with a fibroneural stalk connecting the spinal cord and the cutaneous lesion. It's a dorsal midline defect and covered with skin. And there is this stenting of the spinal cord. In myelomeningocele, there is outpouching of the dural sac along with CSF and along with the neural tissue, abnormal neural tissue, and there is no overlying skin, and this is called myelomeningocele. Myelocele is similar to myelomeningocele, but there is no herniation of the CSF spaces over the skin surface, and it's not covered with skin either. And this is called myelocele. Myeloschisis is similar to myelocele, but it's a severe form of myelocele. And the abnormal neuronal tissue, the neural placode, is protuberant and extending beyond the skin surface. It's very tuberant. Embryogenesis is crucially important in understanding spinal dysraphism. And I wanted to summarize briefly here. I colored the ectoderm in green, mesoderm in red, and endoderm in blue. Initially they are called epiblast, hypoblast, mesoblast, but I just simplified them. As we all know, life starts with a sperm and an ovum forming 2 cells, 4 cells, then morula at the day of 3, and between 4 to 7 days, blastula is formed and eventually forms the amniotic cavity and the yolk sac cavity, which will form the bilaminar disc, and this bilaminar disc will become the trilaminar disc. The disc is important because this is where the embryo will form. And this process for transformation of blastula, which is actually a simple spherical ball of cells, into an organized structure, bilaminar disc, and this is called gastrulation. Massive reorganization of the cells happen at this stage. And after the trilaminar disc is formed, neurulation takes place. During neurulation, the spinal cord is formed by a special ectoderm, which is called neuroectoderm. The ectoderm, some of the cells form into neuroectoderm, which I colored in lighter green. They form the neural plate, which forms the neural groove. This groove is then forms an enclosed tube. That's why it's called neural tube defect. And this is done within 48 days. It's only 7 weeks. The embryo is very tiny. The ectoderm forms the brain and the spinal cord. So once somebody realizes around 7 weeks of life that she is pregnant, the spinal cord is already formed, and folic acid administration is therefore important to start once somebody has the possibility of pregnancy, because once you realize that the person is pregnant, it's too late. The spinal cord is already formed. And there's a very nice saying about gastrulation and neurulation. It's not birth, marriage, or death, but gastrulation and neurulation, which is truly the most important time in your life, because massive cell reorganization happen at this stage. So when there is something wrong, an anomaly, a severe anomaly occurs during gastrulation. The anomalies in neurulation is less severe compared to gastrulation, such as caudal agenesis, diastomatomelia, and focal segmental dysgenesis. And neurulation is actually where primarily the spinal cord is formed, and neurulation is therefore important, and we need to look at the neurulation in detail. It can be categorized as primary, taking place between 18 to 27 days, and secondary as 28 to 48 days. During the primary neurulation, the primary tube forms. If you look at the closure of the tube from above, and this is the correlation with the actual photo of the embryo, the tube starts closing in the mid portion and extends caudally and rostrally in a zip-like fashion. That's why the anomalies occur either caudally or cranially, but not in the mid portion. And this is, the closure is down to the level of S2. And after the primary tube is formed, a mass of cells occur distal to the tube, and cysts occur within this mass, and these cysts coalesce and to form a secondary tube, and this second tube fuses with the primary tube and forms filum terminale, terminal ventricle, and conus medullare. And you can tell that any anomaly occurring above the level of S2, or either closed or open, has occurred during primary neurulation. And these anomalies are listed here, and they are more severe compared to secondary neurulation. And the anomalies that occur during secondary neurulation is primarily filar lipoma, tight filum terminale, persistent terminal ventricle, and terminal myelocystocele. Let's take a look at the primary neurulation from a different angle. During the primary neurulation, there is closure of the tube, which is formed by neuroectoderm, which I showed in lighter green. And there is ectoderm in darker green, which will form the skin overlying the tube. Initially, the ectoderm and neuroectoderm are together, and after a normal embryologic development, they are separated. This is called normal disjunction, and as a result, the cutaneous ectoderm are completely separated by the neuroectoderm, which will form the cord by intervening mesodermal cells. As I showed here, these specific mesodermal cells will eventually form the subcutaneous fat and other soft tissues. If this normal disjunction does not occur, the tube will stay as it is. It's called non-disjunction, and there is no closure of the tube. The ectoderm and neuroectoderm are still not dissociated, and there is no overlying skin. The other scenario is a premature disjunction. This can be focal or incarceration of mesoderm. So there is normal disjunction, but it's premature. So what happens is when there is normal disjunction, the tube is already closed. So the mesodermal cells cannot migrate into the tube. When there is premature disjunction, the tube is still open, and these mesodermal cells can migrate into the tube, which is called incarceration of mesoderm. These cells will eventually form fatty tissue and will form intradural lipomas and lipomyelocele and lipomyelomeningocele. So the intradural component of the fat is not really an extension of the subcutaneous fat, but formed by the originally migrated mesodermal cells. The other scenario will be a focal premature disjunction. So the mesodermal cells do not migrate into the tube, but there is a defect dorsally in the midline. And if the neural tissue is pulled up to the skin side, it results in limited dorsal myeloschisis. If the cutaneous tissue is pulled down to the neural side, it leads to dorsal dermal sinus. After the embryology, I would like to say a few words regarding assessment of the MRI. There are some challenges when interpreting the MRI images. One of them is truncation artifact, also known as Gibbs phenomenon. As you can see here, you may think that there is a lesion in the spinal cord. You may interpret this as a syrinx or an abnormality. You can see it on the axials or even in T1 in the cord. This occurs as multiple fine parallel lines immediately adjacent to high contrast interfaces. You can correct them by increasing the matrix size or by using some specific smoothing filters. CSF flow artifacts are commonly seen during the interpretation of the spinal MRIs. Specifically, they are seen on the T2 weighted images as dark areas. They can be focal or quite extensive, as you can see here. To differentiate them from pathology, they are never seen on T1 weighted images. So when you correlate with the T1 weighted images, you never see them. On the other hand, you can have an dural AV fistula or AVM, as in this case, and there is usually associated spinal cord abnormality, and the vessels can be seen on the post-contrast images. They can be very subtle and can be only detected on the SA and CT. Sometimes it may be difficult to assess the level of the conus. As you can see here, there is the spinal cord. The conus terminates somewhere around here. On the T1, you can tell this is at the level of L1 here, but on the T2, it's not very clear. And this is caused by CSF flow artifacts plus clumping of the nerve roots. So you should always assess with other sequences and more importantly on the axial images. So the level of the conus can better be seen on the axial images. And here, for example, I can see the conus terminating and no conus here. So my level is somewhere here. On the sagittal, it's not possible to determine the level of the conus. We should also use optimized window levels when looking for a sinus tract. So to give an example, there is a dorsal dermal sinus in this case, and on regular window T1, it's not possible to see the sinus tract. But if you optimize the window, if you narrow down the window level, then the tract becomes visible. On the T2 weighted images, this is the regular window. We don't see it. In the optimized window, the tract can be seen. In this slide, you can see the overview of most commonly encountered spinal dysraphisms, and I'm going to use this slide as a roadmap to navigate between them. I would like to start with open spinal dysraphism. The most common one is myelomeningocele. The other three are very rare, and most likely you will see only a few cases in your lifetime. In this patient with myelomeningocele, which is the most common, you can see the placode. Placode means non-neurulated embryonic neural tissue. Basically, it's dysfunctional dysplastic neural tissue. It is not covered with skin, but there is usually a very thin epithelial membrane with rupture soon after birth. In this case, after removal of the bandage, the membrane ruptured because it was attached to the bandage, and it was possible to see the CSF leaking out. So the CSF is exposed to air and there is a risk of infection. So these children require surgery as soon as possible, which will be a life-saving surgery. Imaging can be done for open spinal dysraphism when there is a questionable diagnosis, such as in this case, who had a congenital hemangioma over the spine, but clinically thought to be suspicious for myelomeningocele. So we did ultrasound and MRI, and we made the diagnosis. And imaging can be helpful for detecting associated anomalies, such as hydrocephalus in this case, for kyphosis. So there is an open spinal dysraphism here. We did an ultrasound and an MRI and the CT. You can see the correlation of the ultrasound with the MRI and CT. When there is a myelomeningocele, there is always a KRI2 malformation if the patient was not treated in utero. So imaging can be done for detecting additional anomalies. So myelomeningocele accounts for most majority of open spinal dysraphisms, almost 99%. The neural placode is exposed to air, almost always a posterior bony defect and herniation of the neural elements along with CSF spaces. And there is no overlying normal skin but just a thin membrane, almost always associated with KRI2 malformation and almost always irreversible neurological sequelae below the level of the placode. And there is usually hydrocephalus, but this is changing due to the fetal surgery. And we see more normalized patients after surgery. Okay. Another example of a myelomeningocele. Here you can see the MRI, posterior bony defect, and there is outpouching of the dural sac along with CSF spaces and neural placode. And this is the placode, this is the thin membrane already partially ruptured, and this is the neural elements on the axial plane along with outpouching of the CSF spaces, and almost always KRI2 malformation, and KRI2 malformation is characterized with herniation of the cerebellum, a small posterior fossa, and usually dilatation of the lateral ventricles and Here you can see due to the obstruction at the level of the foramen magnum. The difference of myelomeningocele from myelocele is that there is no outpouching of the CSF spaces, and this is an example of a myelocele. Usually, myelomeningocele is diagnosed in utero by ultrasound, and we can confirm the diagnosis with an MRI. As you can see here, there is defective posterior elements, and we can see the dural sac extending out of the spinal canal on the ultrasound. On the ultrasound, we don't always see the membrane. It may be ruptured, it may be reversibly ruptured, and on the next follow-up you can see the membrane. But even if you don't see the membrane, you should make the diagnosis on the MRI. Here we can see the membrane and outpouching of the neural elements along with CSF spaces, and this is the same child after birth. In utero repair of myelomeningocele revolutionized the treatment. This is the first non-lethal anomaly to be treated in utero and has become the standard care for qualifying patients. It significantly reduces the need for postnatal VP shunt requirement. It improves the motor function, ambulation, and hindbrain herniation, which is KRE2 malformation. The effects of the bowel and bladder dysfunction are variable, but many studies showed improvement. It can be done as an open surgery, fetoscopically, or with a hybrid approach, both laparotomy and fetoscopy. Fetoscopic approach decreases the complication rates, however, the effects of surgery are similar, and there is no difference on spinal cord tethering between pre and postnatal surgery. To give an example of a myelomeningocele with prenatal surgery, our patient gets the ultrasound at 9 weeks old, and we can see the fetus here. As you know, the neurulation is completed by the age of 7 weeks. So the neurulation is completed and the spinal cord is formed, but formed defective. The tube is not complete, is not closed. So there is an open neural tube defect, which was confirmed on the ultrasound at 20 weeks of age. And we can see the posterior bony defect at the level of the sacrum, and we don't really see the neural elements and the membrane, but on the axial we can see the defect nicely, and we can see the abnormal skull, lemon-shaped skull with ventriculomegaly, which are components of KRE2 malformation, and myelomeningocele comes as a package with KRE2 malformation. So we confirmed our findings by fetal MRI at 22 weeks of life before surgery, and here you can see herniation of the cerebellum, ventricular dilatation, colpocephaly, and here myelomeningocele with defective posterior elements, and here is the neural placode. Then the patient gets the surgery around 25th weeks of life, and after the surgery we are checking for the improvement with a follow-up MRI around 30 weeks of life. As you can see, there was significant improvement of the cerebellar herniation here. The defect is now repaired. There is no posterior defect. It's closed now, as you can see, compared to the previous MRI. The crowding of the neural elements at the level of the foramen magnum has significantly improved. On the previous MRI, the posterior fossa was too tiny, and you can't even differentiate the cerebellum, but on the follow-up MRI, we can see improvement of the size of the posterior fossa filled with CSF, and we can now visualize the cerebellum nicely. And this is the repaired spinal defect, and ventriculomegaly still persists. cysts, and we are now able to see these subependymal gray matter heterotopias. And so this was a significant improvement after the surgery. So when there is myelocele, it's similar to myelomeningocele. It's extremely rare, and they're also associated with KRI2 malformation. And as you can see here, and there is the difference between myelomeningocele is there is no outpouching of the CSF spaces. It's only the neural elements. Severe form of myelocele is called myeloschisis by many authors. The neural placode is very prominent, appears as a mass over the skin surface, as you can see here, very prominent, a protuberant mass over the skin surface. You don't need imaging for this. Another example, here you can see the neural placode exposed to air. Another extremely rare type of open spinal dysraphism is hemimyelomeningocele. So there is myelomeningocele on one side, and on the other side the cord is normal, and there is split cord malformation. So there are two cords. One side is normal, the other side has myelomeningocele, as you can see on the axial MRI images. Typically, these patients have symptoms on one side. On the other side, symptoms are not very prominent. This patient had significant motor deficit only on the right side since birth and had the MRI at the age of 28 months. After completion of open spinal dysraphism, I'm going to skip to closed spinal dysraphism with subcutaneous mass and starting with meningocele. Meningoceles are interesting because it's controversial if they are real spinal dysraphisms, because there is no abnormal neurologic elements within the dural sac. As you can see here, there is herniation of the dural sac covered with the skin, but no abnormal neurological elements in the sac. And these children are usually neurologically normal, and meningoceles are not associated with Chiari malformation, Chiari 1 or 2. And usually the etiology is considered to be repetitive pulsation of the CSF rather than a neurulation abnormality. And here you can see an example in the cervicothoracic region. Here you can see a distal meningocele. They're usually common in the cervicothoracic region or distally in the sacral region. As you can see here, there is the dural sac on the T1 weighted image, and on the T2 weighted image we can confirm that there are no neurological deficits and it's covered with skin, and the patient is doing well without any neurological deficits. Another example at the cervicothoracic junction, small bone defect. It's almost always the case, and there is a large dural sac, and you can see this T2 hypointense signal intensity. This is CSF flow artifacts, motion artifact basically. They can also be anterior in the sacral region. As you can see in this patient, there is sacral agenesis and a bony defect, and through this bony defect we can see the dural sac herniated anteriorly into the pelvis and on the coronal as well. There are no neurological elements in the dural sac. The next one in this group of spinal dysraphism, closed spinal dysraphism with subcutaneous mass, is lipomyelocele and lipomyelomeningocele. The differentiation is based on the placode-fat interface. Placode is the abnormal neurulated tissue, basically this plastic non-neurulated tissue, and this is the fat. The placoid fat interface is in the spinal canal in lipomyelocele and out of the spinal canal in lipomyelomeningocele. And there is almost always increased subcutaneous fat tissue. Here is an example of lipomyelocele. The placoid fat interfaces within the spinal canal, and there is increased subcutaneous fat on T1 and T2 weighted images, and here on the T1 weighted images on the axial. There is also a low-lying cord attached to this fat. Another example of a lipomyelocele, the placoid fat interfaces within the spinal canal, and there is a low-lying cord attached to this fatty tissue. On the other hand, in lipomyelomeningocele, the neural placoid fat interfaces out of the spinal canal, and there is outpouching of the CSF spaces as well. As you can see here, there is a low-lying cord attached to this fat, and there is associated hydrosyringomyelia cavity within the distal cord. One of the misconceptions is people think that lipomyelomeningoceles are similar to myelomeningoceles, but they are not. They are actually different. They are closed spinal dysraphisms. They don't need immediate surgery at birth, and neurologically they can be completely normal, and neurologically they are much better than myelomeningoceles. And they are not associated with Chiari malformation, Chiari-2 malformation all the time. They may be associated with Chiari-1 malformation. As you can see here, there is the posterior fossa has normal size, the cerebellum is well formed, but there is herniation of the tonsils through the foramen magnum. This is not always the case. They can be completely normal, but because of herniation of the CSF spaces, there may be some sagging of the cerebellum. This is not always associated. So the Chiari malformation associated with lipomyelomeningocele is completely different than the myelomeningocele. I think it's the same etiology. This is more like a similar to an intrauterine treated myelomeningocele. So the pressure difference is not much, and the malformation is very mild or none. The other thing is the treatment is different because these children usually undergo surgery later in life, and this is a group that surgeons don't like much because it's technically very difficult to remove these fatty tissue among these neural roots, and in a completely neurologically normal patient, neurologic deficits can occur after the surgery. The next item in the group of closed spinal dysraphisms with subcutaneous mass is myelocystocele. In myelocystocele, there is herniation of the dural sac through the bony defect covered with skin, but there is also herniation of the central spinal canal. So there are two different compartments filled with CSF. One is the central spinal canal, hydromyelia, one is the subarachnoid spaces, meningocele. They can be proximal or terminal distal located, and in this one you can see a terminal one distally located. On the coronal images are very helpful. You can see the splaying of the cord, and you can see the central spinal canal, which is very large, and you can confirm the diagnosis. There is associated a low-lying cord and two different CSF filled sacs. So I'm going to review myelocystocele along with limited dorsal myeloschisis because it looks like in the literature there is an overlap of non-terminal myelocystocele and saccular limited dorsal myeloschisis. So, terminal myelocytoceles are completely different than limited dorsal myeloschisis. They are distinct entities with severe neurological abnormality. They are so rare. They may be associated with Chiari-2 malformation, and they are associated with omphalocele, cloacal malformations, anal atresia, omphalocele. But in this limited dorsal myeloschisis, this different entity characterized with a midline defect covered with skin associated with a fibroneural stalk. And these children may have a good neurological prognosis. They can be completely normal, or they can have mild symptoms as opposed to terminal myelocytocele, or as opposed to myelomeningoceles. There are two types, saccular and non-saccular. In the saccular ones, there is associated hydromyelia. In this one, there is not. Although I drew it like this, there is no real lumen, so there is no CSF in it. It's just a fibroneural stalk. And this is the hallmark of diagnosis, demonstration of the stalk in both. So it looks like, because of the associated hydromyelia, like myelocytocele, people called this non-terminal myelocytocele, and they were actually acting quite differently clinically. These are very mild. To give you examples for the limited dorsal myeloschisis, this is in the spectrum of a dorsal dermal sinus tract. As we discussed in the embryology, there is this junction of the cutaneous and neuroectoderm. So here you can see the posterior tenting of the spinal cord at the level of the cervicothoracic junction. It's proximal. There is some herniation of CSF, but not extending above the level of the skin. That's the stalk. And the stalk typically attaches to the skin lesion. It's covered with skin. The skin lesions are characteristic, as you can see here. In the saccular one, there is hydromyelia. There are two sacs, one sac, two sac, and typically attached to the skin lesion. So dorsal midline defect. Clinically, they can be completely normal, and as you may guess, they may be mixed up with myelocytocele or myelomeningocele. This is crucially important in the prenatal diagnosis, because these patients may have an unnecessary abortion because they may be diagnosed as a myelomeningocele. Limited dorsal myeloschisis is associated with typical cutaneous lesions, as published in this fantastic paper. In the non-saccular ones, there is typical crater and pit appearance. This crater appearance looks like a cigarette burn lesion, and it's typical for limited dorsal myeloschisis. The saccular ones are larger lesions. It can be with a thick squamous top, thin squamous top, a dome pit, or a membranous sac, as you can see here. And you can easily guess why they can be considered as myelomeningocele early in life, because the resolution of ultrasound is low, and these lesions really look like myelomeningocele sacs. Here is another example of a non-saccular limited dorsal myeloschisis. As you can see in the sagittal plane, there is a low-lying cord with this bone defect. posterior tenting and the stalk. There is some outpouching of the CSF spaces, but not extending above the level of the skin. There is no associated KRI2 malformation, and you can see the attachment of the stalk to the cutaneous lesion on the axial images and sagittal images. Interestingly, there is a sinus tract extending from skin to the dural sac, and this patient is completely normal neurologically, and there is a protuberant skin lesion with no opening. This patient was reported as myelomeningocele mistakenly in utero. And that was not the only case that was misreported. Here is another case that I misreported as myelomeningocele, and this was even published. This was more than 10 years ago. And here is the dural sac at the level of the thoracic spine, and there are two different sacs, CSF filled sacs, and you can actually see the fibroneural stalk. So this was a limited dorsal myeloschisis circular, but we even published this, and based on this, the pathological findings, we called it myelomeningocele, but in retrospect, I can say that it's not a myelomeningocele. So limited dorsal myeloschisis is confused with myelocystocele, but they are different because of the associated hydromyelia, and confused with myelomeningocele because of the associated dural sac with some elements in it. And also histopathologically, they are in the spectrum of dorsal dermal sinus tract. So it is a great mimicker. How do we differentiate limited dorsal myeloschisis from dorsal dermal sinus? Because they are histopathologically in the same spectrum. There are some differences. First one is the cutaneous lesion. In limited dorsal myeloschisis, there is typical characteristic cigarette burn mark. In dorsal dermal sinus, there is dimple or a pinpoint ostium. There is a real hollow tract lined by epithelium in dorsal dermal sinus, but in limited dorsal myeloschisis, it's a solid tract without a lumen. And because there is no lumen, there is no increased risk of infection in dorsal myeloschisis, so you don't need to do immediate surgery, urgent surgery in neonatal period. And they are not associated with dermoid cysts because the epithelial cells do not migrate into the thecal sac. However, in this group, urgent surgery is required to avoid infection, and they are commonly associated with dermoid cysts. In limited dorsal myeloschisis, the intrathecal tracts are entirely or partially visible. You can follow them. But in dorsal dermal sinus tract, they are poorly visible. You can't see them after entering the thecal sac. In limited dorsal myeloschisis, tracts are attached to the spinal cord above the conus with characteristic dorsal tenting, like a beak. But in dorsal dermal sinus, the tracts terminates in various structures, including dermoid cysts. After completion of the open spinal dysraphisms and closed spinal dysraphism with MS, I'm starting the third group, which is closed spinal dysraphism without a subcutaneous mass. In this one, there is no mass, and there may be a cutaneous marker, as you can see in this case, or it may be completely normal by inspection. The first one in this group is filar and intradural lipoma. As you may remember from the embryology, these are formed in situ by the mesenchymal cells that migrated into the canal before it is closed. So that before the tube is closed, the cells have moved there and they form the lipomas in situ rather than extension of the subcutaneous lipoma. Here you can see the intradural lipoma with typical T1 and T2 hyperintense appearance and completely saturated on fat saturated images. There's a low-lying cord and the lipoma is attached to it. and here is the axial correlation on T1. They don't have to be in this sacrococcygeal level, but they may also be in the proximal level as well. As you can see, this T1, T2 hyperintense appearance and completely saturated. There is no connection with the subcutaneous mass. But this is actually the most common type, filar lipoma. Filar lipomas only involve the phylum, as you can see here on the T1 weighted images, on the sagittal and on the axial. On T2 it's harder, but it's still there. So these are very common in the population, up to 5% of the population. When they are not associated with a low-lying cord and there are no symptoms, the treatment is usually just observation. They may be detected on the ultrasound, although it's difficult. Here is a case of a very thin filar lipoma on the ultrasound. It is slightly hyperechoic, but on the MRI you can confirm this T1 hyperintensity and confirm the diagnosis. When we are talking about lipid-containing anomalies involving the lumbosacral region, we should know that these are a spectrum of anomalies rather than distinct specific anomalies. And we should be more descriptive if we don't know what that anomaly is. Here is some descriptive terminology. So the lumbosacral lipomas is an umbrella term, and you can describe them as dorsal lumbosacral lipomas because two different examples, the lipomas are attaching the cord from the dorsal aspect. Or you may describe them as caudal lumbosacral lipomas because the lipoma is attaching the cord from the caudal aspect. Or they may attach the cord both from the dorsal and caudal aspects, as you can see in two different patients here. And we have the lipomyeloceles and lipomyelomeningoceles. They are almost always associated with increased subcutaneous fat and a bone defect and a low-lying cord. And it may be difficult to differentiate between these two groups. And the best way is to call them lumbosacral lipoma and be very descriptive in the reports. And we have the filar lipomas as we discussed. And this is the simplest form of the anomaly. There are many different classification systems, as you can see by Chapman, Errol, Pang, and Morota. This one, categorizing into 4 different types, is very commonly used, and there is a classification system based on just embryology, as you can see here. These groups overlap each other, as you can see here. This group, especially this part, and some authors call it chaotic lipomas, is overlapping with the lipomyelomeningocele group and also type 2 in Morota. And this group has the worst prognosis, and the treatment is not as successful as the other groups. And this group, filar or type 4 or some of the terminal anomalies, has the best prognosis after treatment. After the lumbosacral lipomas, the next topic is tight phylum terminale. We can also call it a tethered cord. It basically describes abnormal fixation of the spinal cord in the spinal canal, which results in mechanical stretching and distortion and ischemia of the cord during daily activities, normal growth, or development. We can detect them during the newborn period by an ultrasound. As you can see here, that's the low-lying cord, and here you can see the MRI correlation of the cord. So how does a normal phylum look? on the ultrasound, it is anterior to the roots of cauda equina here, and another one here. They are thin, usually up to 1 millimeter or 2 millimeter. In adults, it's 2 millimeter. And this is just a slightly echogenic structure that has no function, but it is attaching the medullary conus to the distal aspect of the dural sac. And when there is tight filum terminale, we see the low insertion of the cord. As you can see here, the cord is low lying. With the correlation of MRI, the cord is low lying. And on the ultrasound, we don't see the normal pulsatile motion of the spinal cord. This is the B mode ultrasound. So here is another tethered cord. We don't see much motion on the B mode. As you can see here on real time, it normally has a freestyle motion, but this one has very limited motion and appears tethered. And this is the panoramic view of the spine and nicely demonstrates the low-lying conus. So this is also called tethered cord, tight filum terminale, and where are associated symptoms and signs, it is called tethered cord syndrome. And here they may be completely asymptomatic, or they may have some symptoms, as you can see in a 2-month-old and 8-year-old with numbness in the toe. In the early gestational life, the spinal cord is at the same level of the vertebra, but because the bone grows faster, a discrepancy occurs between the spinal cord and the vertebra, and when the baby is born, it is usually between L2 and L3 level, maybe as low as L3, mid L3 in the preterm, but in the term the discrepancy is more significant, and usually it lies between the level of L2 and L3. And in the adult life, the level is usually around T12 and L1. As you can see here, normally the nerve roots take a longer course, but when there is a low-lying cord, the nerve roots are shorter and course a shorter route, and as you can see here, so they are not well formed when there is tethered cord. Determining the level of the conus is very important, and usually in the newborn we do it with an ultrasound, and here you can see the ultrasound correlation of a panoramic image with the sagittal T2 images. This is the normal level, and on the axials we can see them. We are now seeing the roots. This hypoechoic structure is the cord, and here is a tethered cord. Just to give examples here, so this is a patient, 2-day-old. We are doing the ultrasound, and we detected the low-lying cord. It's a tight filum terminale or tethered cord, but there are no symptoms. And we are doing a follow-up for this syrinx, and the syrinx is not growing much. The baby is 5 weeks old, and another follow-up at the age of 2. Syrinx is slightly more prominent. Tethered cord, no other lesions noted, no lipomas. And the patient gets the surgery at the age of 5 years, and this is the last follow-up. As you can see here, the syrinx has resolved, but the level of the conus is still same, because at surgery what they do is just cut the filum and just leave it like that. And on the Last follow-up, the patient is doing well, no symptoms, and playing hockey. Another example of a tight phylum terminale. This patient has no symptoms and presenting at the age of 7 at the MRI because of a hair tuft in the lumbosacral region. There is a low-lying cord attached to a very tiny lipoma. The cord is at the level of L4. And around the age of 10, the patient develops some symptoms as intermittent numbness on the top of both feet and pain in the shin. And on the MRI, not much has changed. We still see a low-lying cord attached to a lipoma. And the surgeons decided to do the surgery at this level. And after the surgery, we see partial removal of the lipoma. It is not easy to remove these lipomas because they are around the nerve roots. And the cord is still low-lying, although the phylum is cut. The conus level has not changed as expected. And the patient's symptoms have not resolved completely. They are still going on, but they are less frequent, and the symptoms have improved. Another example of a 6-month-old with a tethered cord and a syrinx. So this is one of the reasons to do the surgery. If there's a syrinx, surgery is preferred so that it doesn't progress, because when you cut the phylum, usually the syrinx cavities resolve. As in this case, we can see it, although there were no symptoms, the surgeons decided to do the surgery because of the syrinx. Next one in the list is persistent terminal ventricle. It's a very benign anomaly. It's called terminal ventricle, also called fifth ventricle. It basically a cystic dilatation in the medullary conus, and the treatment is controversial. If there are no symptoms, the treatment is usually observation. If there are symptoms, the cord can be cut, and this is very benign, but we should be careful not to overcall this. For example, in this one, there is a cystic dilatation of the cord with a septation, and this is not a persistent terminal ventricle. This is a more severe anomaly. During the newborn period, when we are doing the ultrasound, we can see transient canal dilatation on the ultrasound, and here is the canal. There is usually not much CSF within the central spinal canal, so we don't see the canal like this. So this doesn't happen all the time. And on the MRI, we can see that this is like the previous finding of terminal ventricle, this slight dilatation of the canal, but it's called transient canal dilatation. This transient canal dilatation is a description for newborns, but we sometimes see dilatation of the canal distally in older patients, as you can see here. These patients are usually asymptomatic, and they usually get a diagnosis of hydrosyringomelia, but the location is typical, not associated with any anomalies, and they resolve without any intervention over time, as you can see in this child. At the age of 16 years, it was almost completely resolved. Filar cysts are common, and they should not be considered as an anomaly or a tumor. Here you can see a very typical one. They are usually located distal to the cord. They're not in the cord, and on the ultrasound they can be seen better, but if you get some high resolution images, you can see the cysts in the newborn period as well. They usually resolve after a few weeks, and here is the MRI correlation. To summarize the normal variant in the neonates, we have terminal ventricle. The cyst is within the cord. Filar cyst, cyst is distal to the cord among the nerve roots, and there we have the transient central canal dilatation, that the central canal is filled with CSF and we can see it. These are all transient findings and should not be confused with pathology. We should be careful when calling a normal variant. For example, in this patient, this is not a normal variant, although the central canal seems to be dilated. This is not a terminal ventricle because there is two of them, and there is an associated low-lying cord. The conus is at the level of L4 almost, and there is an associated anomaly, a lipoma, as you can see here, and with the MRI correlation. The same side the patient is prone in the ultrasound, that's why we see it on the other side. We see the lipomas, and here on the MRI you can see the cysts. So when calling a normal variant, everything else should be normal. Dorsal dermal sinus is the next one on our list, with a closed spinal dysraphism without a subcutaneous mass. These sinuses may reach the subcutaneous fat, bone, dura, subarachnoid space, or the cord. The subcutaneous portion can be better seen compared to the intraspinal portion. These are real epithelium-lined sinuses that connect the skin to the CNS and its meningeal coating. Most common in the lumbosacral region because they originate from during the primary neurulation. They usually are located above the level of S2, not during the secondary neurulation. Here is an example of a dorsal dermal sinus tract associated with an epidermoid cyst. The most important thing for the surgeon is to find the sinus throughout its entire course and resect it completely, because partial resection will result in recurrence of epidermoid cyst or infection. As a radiologist, our role is to show the sinuses nicely. For example, in this patient with an atypical dimple associated with a cutaneous marker, we did ultrasound, CT, and MRI. On the ultrasound, we can see it, but it's very limited. Here on the axial image T2, we can also see them on CT if we are doing a CT study, that we usually don't do that much. Here is the sinus tract nicely seen on the T1 and T2 weighted images. It's important to play with the window settings to see the sinuses better on the MRI. This is associated with a low-lying cord, as you can see. Dorsal dermal sinus tracts are important due to their complications, and they require surgery during the newborn period because they may be complicated with epidermoid cysts or infections. As you can see here, there is a sinus tract and there is a cyst here within the distal spinal canal that is best seen on the diffusion weighted images. This is an epidermoid cyst, and this is best seen with the diffusion weighted images. So this is one of the common complications of dorsal dermal sinus tracts, secondary to migration of the epidermal cells into the spinal canal. The second complication is infection, which is more serious. And here you can see the example of an infected sinus, which is extending all the way into the spinal cord, which is low-lying and associated with a small epidermoid cyst. And the patient had the surgery, and this is after the surgery. You can see the resection of the posterior elements, and the infection and symptoms reoccurred. So we did the MRI, and there is this cyst actually, which is an epidermoid cyst, and we could also show the recurrent infection by ultrasound because there were no bony elements posteriorly. So what happened in this patient is the surgeon couldn't resect the sinus all the way, and it reoccurred, and the patient had multiple surgeries afterwards. And because of recurrence, here is the recurrent lesion. This is an epidermoid cyst as shown on the diffusion weighted images, and no contrast enhancement, and the low-lying conus is still seen. Dimples are important because they may be signs of spinal dysraphism. They are small depressions or pits in the skin, most with a visible floor. And it looks like when they are not in the midline in the lumbosacral region or when they are on the cheek, they have favorable prognosis. The level of the dimples is very important for the risk assessment. For example, here coccygeal dimples at this level, and some people used to call these ones when they cannot see the floor, they call it pit, but usually they can be used interchangeably. And this is the intergluteal level, coccygeal, intergluteal, and above the intergluteal sulcus. So the location, the level is very important. At the coccygeal level, there is no increased risk for spinal dysraphism. When they are intergluteal region, here, there is increased risk, but not very high. But when they are above the level of the gluteal cleft, gluteal sulcus, then there is significantly increased risk. For example, here with an increased risk because the lesion is way above the level of the intergluteal sulcus, as you can see it, and here. So the lesions at this level, at the coccygeal level, has no increased risk. In this patient with a coccygeal dimple, without a visible floor, on the ultrasound we can see the sinus tract extending between the tip of the coccyx and the dimple. And on the MRI we can see this short tract, barely. As you can see, it is not extending into the spinal canal, which is at the level of S2. So these tiny tracts or sinuses at the level of coccyx, either associated with a dimple or not, do not cause any clinical problems, and they are not associated with spinal dysraphism or epidermoid cysts or infections. Here is an example of high and low sinus tracts in the same patient. This is a pathological dorsal dermal sinus tract. It's real and it's associated with this lipoma and other anomalies. But in this patient, we have this coccygeal tract as well, and this has no clinical significance. This one is important. So in the newborn, we do screening ultrasounds for suspected patients. So these are basically patients who have dimples, but not every patient with a dimple needs an ultrasound. These dimples, when they are high risk, we should do an ultrasound. When they are low risk like this, we don't do an ultrasound. How do we differentiate? So in the simple dimples, they are in the midline. They are smaller than 5 millimeters. They are within 2.5 centimeter of the anus, and there are no associated skin lesions. In the atypical dimple, they may be in paramedian location, larger than 5 millimeters, 2.5 centimeter above the anus, and there may be associated skin lesions. Understanding the normal anatomy of the coccyx and variations is important because the anomalies here can be misinterpreted as spinal dysraphism. The coccyx is formed of 3 to 5 coccygeal vertebrae, usually rudimentary, as you can see here, still cartilaginous mostly, and we can see it as a hypoechoic structure. The first coccygeal vertebra is usually ossified at birth, and here we can see on the X-ray and ultrasound it has this typical round ossification center as opposed to rectangular ossification center in the sacrum. It shows this slight bending, a physiologic kyphosis. And there are some variations. It may be lengthy or shorter with a slight posterior angulation with an anterior beak, posterior beak, an abrupt ending here. These are some variations. When the coccyx does not show the physiologic kyphosis and extends posteriorly to the skin surface, there is usually an associated dimple. And because the coccyx is a hard structure, it can be palpated under the dimple and may be misinterpreted as a spinal dysraphism. I like the term of dysmorphic coccyx to describe this entity. Here is another example of a dysmorphic coccyx with an atypical dimple because it's large, and on the ultrasound the coccyx, cartilaginous coccyx, is extending to the skin surface where there is dimple, and this was palpated as a hard lump by the physician. Another example is a simple dimple, and on the ultrasound and the physician is palpating a hard lump here. And here is on the MRI, we can see that there is actually no spinal dysraphism, but the coccyx is extending to the skin surface instead of doing the physiologic kyphosis. And this is palpated by the physician and is associated with a dimple. And this dysmorphic coccyx can be associated with a pseudosinus tract. I like the term pseudosinus tract, which many authors prefer, because some of them were resected and shown to be not shown to be a pseudosinus tract rather than a sinus tract with a lumen. So they are just fibrous bands extending between the tip of the coccyx and the dimple here, and they do not extend to the spinal canal, and they don't have an opening, so they are not at risk for an infection or epidermal cysts. And these should not be overcalled as spinal dysraphism, and they do not require a further investigation with an MRI. Next anomaly is caudal agenesis. This is a closed spinal dysraphism without a subcutaneous mass. There may be a skin lesion or not, and this is considered to be a complex anomaly among these anomalies. The term caudal agenesis is a radiologic term that we describe what we see, but if there are signs and symptoms, you can use the term caudal regression syndrome clinically. And basically, there are two forms. One is more severe, one is milder form, and this is the normal for comparison. And sacrum, you can see a few of the sacrum in the severe form, and there is usually the sacrum is mostly formed in the milder form. The importance is the severe form is associated with a high conus, and the milder form is associated with a low-lying conus. And the approach is, this is conservative, there is not much we can do regarding this patient, but in this group, a surgery can be done for the resection of the phylum. In the severe caudal agenesis, the conus is in high position and it has a blunt ending. And in the milder form, there is a low-lying cord attached to the posterior aspect of the spinal canal. Here's a severe caudal agenesis with a high conus and typical extension of the nerve roots anterior and posteriorly, and this was confirmed with the CT scan. And here is a caudal agenesis with a low-lying conus, and this is associated with a lipoma, and here you can see only a few of the sacral vertebrae. Another example at birth. This is on the ultrasound, we can see a low-lying conus, and on the MRI we can see the low-lying, and the sacral vertebra is missing. We don't see the coccyx either. So this is a low-lying conus, and this patient will require a surgery. One of the reasons to do the surgery is the syrinx cavities. So in this patient with a sacral agenesis, there is only 3 sacral vertebrae. There is low-lying cord associated with the syrinx, as also demonstrated on the ultrasound. And after the surgery, we can see the resolution of the syrinx cavity. Caudal agenesis may be associated with other anomalies, and this association is called vectoral association. V represents vertebral anomaly, A anal atresia, C cardiovascular anomaly, TE is tracheoesophageal fistula or esophageal atresia, R is renal or radial bone anomaly, L is limb or extremity anomaly. This patient was born and had the X-ray showing the extremity anomalies and spinal anomalies better confirmed on the CT study. This is an umbilical venous catheter extending to the liver. So here we can see the vertebral anomalies and absent lumbar and sacral vertebrae, and there is contraction of the extremities at the knee joints. As on the sagittal MRI images, we can see the sacral agenesis with high conus. There is horseshoe kidney anomaly, esophageal atresia. The patient clinically had anal atresia as well. So this was a complex anomaly. And when there is sacral agenesis or anal atresia, these patients may need further investigation for these associated anomalies. Next anomaly is split cord malformation. This is characterized by separation of the spinal cord into 2 usually symmetric halves. This is located in this group of complex closed spinal dysraphism without a subcutaneous mass. So it may be difficult to detect these anomalies if there are no skin lesions, if everything else is normal by inspection. So there is type 1 and type 2 anomaly. Type 1 is also called diastematomyelia. Type 2 is diplomyelia. The difference is there is a bony or cartilaginous septum and 2 separate dura in type 1, and in this one there is no bony or cartilaginous septum. There may be a fibrous septum and the dura is common. On MRI there is usually a low-lying cord, and in type 1 we see 2 separate dura and there is a septum. In this case the septum is bony as confirmed the CT study, and in type 2 there is no septum but there is splitting of the spinal canal in a common dura. The presence of septum is important for the surgeons because it needs to be resected. If there is a residual septum, then it may require another surgery. That's why some of the surgeons prefer a CT study to confirm the presence of a bony septum. Another example of a split cord malformation type 1 that we detected prenatally. Here is the prenatal MRI showing splitting of the cord on the coronal and axial images. The baby was born with an atypical dimple which was in high position associated with vertebral anomalies, and also we were able to see this bony septum within the spinal canal. When we did the postnatal MR imaging, we were able to see that bony septum on the coronal images. Coronal images are best, and on the axial we can see that the bony septum, a partial, and on the ultrasound we were able to see two separate cords and this bony septation. Type 2 is the milder form of type 1. Basically, there is no septation and the cord can fuse again. Here, the cord is normal here and normal distally, but there is splitting in between, and on the axial we can see that. There is no septum in this case. In our routine practice, we don't get coronal images, and for split cord malformation, that might be important. On the sagittal images, we usually see a low-lying cord. The cord contours show irregularity, you can see, but you cannot confirm the split cord on the sagittal images. Axials are nice, but if it's involving a short segment, you may miss it. And here I'm showing it. So you should be careful not to miss a short segment mild form of type 2 split cord malformation. Finally, there is focal segmental dysgenesis as the last anomaly. This is a very severe form of spinal dysraphism. Basically, there is disruption of the spinal cord into two, as if the cord is cut into two, and there is a significant kyphosis at the cutoff level. As you can see here, there is this proximal cord and there is distal cord, as if there was a trauma and the cord is cut into two. Typically, we see the distal cord larger than the proximal cord. So that's although it's cut, it's disrupted, it appears thicker. This is very severe and the patients are usually paraplegic since birth, as in this case we did the MRI at the age of 15 months and the patient was paraplegic since birth. So we did a comprehensive review of spinal dysraphism by showing case samples and by using this classification system. So I hope this was helpful. Thank you so much.